Good afternoon, everyone. I'm just a first-year PhD student in the Psychology and Health programme, so I'm just going to give a very brief overview of my current research and what I actually plan to do. So I suppose the overall focus of the research is on digital health interventions to support self-management of asthma in young adults, which we've defined as 15 to 30-year-olds for the purpose of this research. And as Martin outlined earlier, adherence to medication is a significant problem across many chronic conditions, but I'm particularly interested in asthma because not only is it a leading cause of morbidity worldwide, it's actually the most common chronic disease in Ireland, so it affects up to 10% of the population. And because it's so prevalent, there appears to be kind of a common misperception that it's quite a benign disease that doesn't really have a big impact on quality of life, which might partially account for why it's so poorly controlled. So up to 60% of people living with asthma don't have their symptoms under control. And this leads to at least one asthma-related death every week and one A&E visit every 26 minutes in Ireland. So maintaining that control then depends on patient adherence to self-management behaviours. So that includes symptom and trigger monitoring, using an asthma action plan, but the most critical behaviour seems to be adherence to inhaled corticosteroids, or preventer inhalers as they're more commonly known, because these are the most effective controller medication for asthma. But unfortunately, adherence to this type of medication also remains quite low, particularly among adolescents and younger adults. So it's consistently been reported as 30% or even less than 30%. And as we've seen today, digital health holds huge potential to support self-management of health, specifically smartphones, which are almost universally used within this young adult target population. So designing evidence-based treatment adherence supports into or around this technology has potential to be successful within this context. And a recent review published just last year found that mobile technology interventions can effectively support asthma self-management, so they can increase treatment adherence, quality of life and asthma control. But this was conducted in children and adults. So evidence of their effectiveness in young adults specifically has yet to emerge. And in addition to their clinical effectiveness, a study published just last week, actually in the Journal of Medical Internet Research, evaluated patient satisfaction and their perceived usability and value of using these interventions to support self-management of asthma. And they found that up to 80% of patients reported being very satisfied with the intervention, and that the majority of the participants perceive value in actually using this technology to support self-management of their health, and asthma in particular. And I think that kind of gain in this insight is just as important as determining the clinical effectiveness, because that's what will largely determine the patient engagement with the intervention and then kind of in turn the effectiveness of the intervention. So I've decided to focus on this age range for a number of reasons. So first of all, 15 to 30-year-olds have reported the lowest levels of adherence to inhaled corticosteroids. Secondly, by age 15, adolescents have often taken complete control for their daily preventer medication, so kind of independent of their parents. And finally then, this age range also incorporates an important development period in the lifespan, referred to as emerging adulthood. So that refers to 18 to 24 years of age, where young adults with chronic conditions are gradually taking on responsibility for their health. And recent work on asthma and emerging adulthood has kind of identified this as a neglected but a really important period to study self-management of asthma, and that a greater understanding of the psychosocial needs of these young people transitioning from kind of paediatric to adult healthcare is needed. So I suppose then the aim of my PhD is to link digital technology, emerging adulthood and the self-management of asthma in an attempt to answer my research question, which is, can these interventions, like those delivered via smartphones, support self-management of asthma in this population? And I'm proposing to conduct 3 studies to try and answer this question. So the first study will be a systematic review. My 2 review questions are, what is the prevalence of and what are the predictors of adherence to ICS among young adults? So it's a review of quantitative studies on 15 to 30-year-olds who are currently living with asthma and using or have been prescribed a form of ICS. So it's going to aim to provide a quantitative synthesis of a prevalence estimate and a narrative synthesis of predictors of adherence that are assessed in the studies. And then the second study hopefully will involve the actual development of the digital intervention using the person-based approach. So this is a systematic approach to intervention development, and it involves kind of 2 key processes. So the first involves a developmental process involving qualitative research to gain a kind of better understanding of the psychosocial context of the target user population. And then the second process involves identifying guiding principles or intervention design objectives and how the intervention will actually achieve these aims. So accordingly then, I'll conduct focus groups with young adults living with asthma, and I'm hoping to recruit these from GP sites within the Galway region. So proposed content of the intervention will be developed using evidence generated from the systematic review on the predictors of adherence. And this will be presented then kind of using paper representations to focus group participants to try and gain an understanding of their perspective of the proposed content. And then hopefully based on their feedback we can make modifications and present the changes to subsequent focus group participants. So I'll use Brown and Clark's systematic analysis guidance to analyse this data, and then hopefully the intervention will be developed. I've said for now using LifeGuide open source software, but that could change. I'm not too sure on that. I suppose it'll depend on what we think is most suitable after doing the systematic review and doing some of the qualitative research. And then finally, my third study will be a usability and feasibility assessment of the actual intervention in a population of young adults living with asthma. So participants are randomised to either the intervention or control group. They'll be asked to use their assigned intervention for approximately 8 weeks and then to complete the follow-up study. So I'm aiming to recruit at least 59 participants to detect a problem with 5% probability in a study participant. So again, my sample size is kind of aimed at problem detection as opposed to the power of the study. And then usability will be measured using quantitative methods, and feasibility will be measured using qualitative methods. So it's kind of like mixed methods research. Descriptive statistics will be used to analyse usability data, and a summative content analysis will be used to analyse feasibility data. And this type of content analysis involves counting the frequency of specific words or content, but also trying to understand the underlying context of these words. So hopefully then the implication of these studies, or the potential implication, will be the development of a usable and feasible digital intervention for adherence to ICS in a population of adults living with asthma that might be ready for a pilot RCT. And yeah, that's me.